Hello, my name is Taylor Slaney. The date is 12/18/2022, and this is my fourth and final case connection project. So in this case connection, we will be exploring cases 1 and cases 2. In case 1, a patient presents with increased lethargy and elevated ammonia levels. And in case 3, our patient, who is a 47-year-old male, presents with pain in his great right toe and increased plasma urate with low urinary uric acid. In case study 1, our patient is a newborn girl who was born a normal birth weight, but just 24 hours after birth, she is lethargic, hypothermic, and apneic. Labs are drawn and initial blood work shows elevated ammonia levels, indicating a metabolic disorder. In this first case study, we will explore the urea cycle and what biochemical processes are at work. Our second case is case study 3, and as I stated, we'll be meeting a 47-year-old patient who comes into the clinic complaining of pain in his great right toe. Based off of labs that are collected and clinical presentation, a diagnosis of gout is made. So in case study 1, our newborn female patient has lethargy, hypothermia, and is apneic 24 hours after birth. The attending physician suspects a metabolic disorder and orders labs to be drawn. The results show elevated ammonia levels that are rapidly rising. Ammonia is produced by the catabolism of a variety of amino acids. Most blood ammonia originates from the catabolism of dietary protein in the gut through the process of glutamate dehydrogenase, which catalyzes glutamate to its transamination product alpha-ketoglutarate and ammonia. Alpha-ketoglutarate removes the amino group from the amino acid, further breaking down the proteins. Ammonia then enters the circulatory system via the portal vein, where it travels to the liver to be packaged into urea and excreted through the kidneys in the urine. Most of the waste nitrogen produced in the body is packaged into glutamine. Glutamine synthase catalyzes the conversion of ammonia and glutamate to glutamine. Glutamine then acts as a carrier of waste nitrogen until it enters the cells of the intestine or liver to be deaminated, releasing the ammonia ion through the process of glutamase catalysis. Ammonia is 1 part nitrogen and 3 parts hydrogen. The majority of ammonia is broken down into urea in the liver and then excreted by the kidneys. What remains of the ammonia, which again is the 1 part nitrogen and 3 parts hydrogen, is oxidized and utilized in the anabolic pathways such as gluconeogenesis, which occurs in the liver. So further lab analysis of this newborn female patient shows urine orotic levels that are significantly elevated and a plasma citrulline level that is slightly low. Orotic acid is a sensitivity marker of the liver's capacity to convert toxic ammonia to non-toxic urea that can be excreted by the kidneys. High orotic acid levels indicate ammonia toxicity and can result from inborn errors of ammonia metabolism. Elevated orotic levels are typically synonymous with a decrease in citrulline levels due to the decrease in the enzyme ornithine transcarbamylase, which is an enzyme that participates in the urea cycle. Recall that the urea cycle is a cycle of biochemical reactions that produce urea from ammonia, utilizing several different enzymes in the process. And in this next slide, I've got a picture of the urea cycle at work. The urea cycle processes excess nitrogen that is generated when protein is broken down by the body into a compound called urea that is excreted by the kidneys. It is important for excess nitrogen to be excreted because accumulating nitrogen will form ammonia, which is toxic, especially to the nervous system. Hence why our young patient is presenting with lethargy and other symptoms of a neurological disorder. Ornithine transcarbamylase, one of the enzymes involved in the urea cycle, is an enzyme that catalyzes the reaction between carbamyl phosphate and ornithine to form citrulline and phosphate. A deficiency in ornithine transcarbamylase will lead to an increase in carbamyl phosphate, which eventually is converted into orotic acid, therefore increasing levels. Decreased ornithine transcarbamylase will also cause a decrease in citrulline, as observed by this patient as well. The decrease in citrulline occurs because of a disruption in the urea cycle caused by a deficiency in ornithine transcarbamylase enzyme. Ornithine transcarbamylase role is to control the reaction in which two compounds, carbamyl phosphate and ornithine, form the new compound citrulline. When there is a deficiency in ornithine transcarbamylase, this process is unable to occur and therefore will result in lower levels of citrulline. With this specific patient, more tests would need to be run to determine what exact urea cycle disorder she has. For now, our goal will be to manage symptoms and decrease ammonia levels by stopping protein intake, starting this patient on IV fluids, and initiating first-line medications. Once the patient is stabilized, long-term management of this disorder can be discussed with the parents. It is essential to minimize nitrogen load on the urea cycle by decreasing protein intake. The patient will also need to take essential amino acid supplementation for the rest of her life to achieve normal growth and metabolic stability. So, case study 3. In case study 3, we meet a 47-year-old patient who presents with severe pain in his right great toe. He states that this pain started yesterday and that it continues to increase in severity. He does not report any recent or apparent trauma to the right foot, and because of his symptoms, labs are drawn and a urine sample is collected as well. Serum blood levels show elevated plasma urate, while the urine sample shows decreased levels of urinary uric acid. Based on his symptoms and labs that are drawn, a diagnosis of gout is made. The labs collected by this patient indicate that his plasma urate is elevated because of a decrease in urinary excretion of uric acid. Patients that do not metabolize purine, the compound that forms uric acid appropriately, will present with labs that show hypouricemia and hypouricemic urine, but excrete excessive amounts of purine in the urine, which does not align with the labs from this 47-year-old patient. To create uric acid, both hypoxanthine and guanine are needed to form xanthine, which is converted into uric acid. Purine salvage is a process that changes hypoxanthine back to IMP and guanine back to GMP to be used for RNA and DNA synthesis. This is possible with the enzyme HGPRT. Lack of this enzyme will prevent effective purine salvage and will therefore cause an increase in serum levels of uric acid. Laboratory tests need to be done to determine if HGPRT is active and functioning appropriately for this to be considered as a possible explanation for this patient's increase in serum plasma urate. After further discussion with this patient, he mentions that he switched from, and these are some pictures of gout and how it affects the toe. After further discussion with this patient, he mentions that he recently switched from diet soda to regular soda because he read that the fake sugar in diet soda was bad for him. He also informs you that he drinks between 4 to 5 liters of soda a day. Diet sodas are sweetened with sugar substitutes such as aspartame or stevia, whereas regular sugars are sweetened with fructose or high fructose corn syrup. Fructose can trigger a gout attack because the body will break down fructose into glucose 6-phosphate, which will enter the pentose phosphate pathway to create ribose 5-phosphate. This will increase synthase of PRPP and therefore more purine due to the increase in pentose sugar. Purines produce uric acid, which is a substance that forms painful needle-like crystals in the soft tissues and joints that cause gout. Gout is a common form of inflammatory arthritis that can cause intense, painful flare-ups in individual joints throughout the body, but most common is the big toe. An estimated 8 million Americans suffer from gout attacks, which can last for a few days. If not managed, the condition can become chronic and lead to the destruction of the joint over time. Purines occur naturally in the body, but can be found in certain foods and beverages. So in this next slide, I just have some pictures of things that can cause and trigger gout attacks, and then ways to hopefully prevent gout attacks from occurring, and then managing them when they do. So the most likely culprit to this patient's gout attack is his excessive consumption of soda. 4 to 5 liters of soda a day is far too much. So education on a healthy diet will need to be done for this patient to not only prevent future gout attacks, but to also help with his overall health. Education on decreasing all soda consumption, diet, and regular does need to be done. Other long-term treatment plans for this patient include increasing physical activity and losing weight. When a flare-up does occur, self-care treatments including icing the affected joint and resting the area to decrease pain while taking analgesics and NSAID medications such as Tylenol or ibuprofen. If high levels of uric acid continue and frequent gout attacks occur, the patient may be prescribed a uric acid reducer such as allopurinol. So that completes my fourth and final case connection video. Thank you so much for watching.